This podcast is for educational purposes only and does not provide medical advice or create a doctor-patient relationship. Please do not rely solely on this discussion. Always consult your own healthcare provider and verify information independently. If you're in crisis or experiencing a mental health emergency, call 911 or go to your nearest emergency department.
Today's guest is Dr. Cabrera, an associate professor with the Department of Psychiatry at Queen's University and a senior associate researcher at Providence Care in Kingston. He has trained in Spain and the UK and obtained an MSc in neurochemistry from the Institute of Psychiatry in London, and he is both a member of the Royal College of Psychiatrists UK and a fellow of the Royal College of Physicians and Surgeons of Canada. With a career spanning major clinical and academic roles, his clinical and research work focuses on mood disorders, psychopharmacology, and neurostimulation, with numerous publications in leading journals. Casi, it's an absolute pleasure to have you today for our podcast. And really, today the idea would be to speak specifically on bipolar disorder.
Okay.
So for listeners who may be unfamiliar, what is bipolar disorder and how does it differ from typical mood swings or depression?
Well, first of all, thank you very much for asking me to be here. For me, it's a pleasure. And I'm very honored. You know, we are good friends many years ago.
Mm-hmm.
And I'm very, very pleased to be here with you. I can stick to the conventional definitions of what bipolar disorder is, but it refers to periods of significant depression, pathological depression, which can be followed by periods of euphoria, of expansive mood that is also dysfunctional.
Mm-hmm.
So I would refer to those two poles.
Mm-hmm.
As you know, now things are a bit more complicated and the Americans rediscover the mixed episodes.
Mm-hmm.
And whereas before we would refer to various stereotypical episodes of mania,
Right.
and elated mood and hyperactivity, followed by episodes of melancholic depression.
Mm-hmm.
Now what they are saying is that there is a mixture of both conditions, and we can talk about some polarities and manic episodes with mixed features of depression, and then depressive episodes with mixed features of mania. But it would refer fundamentally to periods of pathological mood that would reflect in the form of euphoria, followed by periods of pathological mood,
Right.
referring to severe depression and what I like to call melancholy.
When we talk about pathological changes in mood, you know, normally we normally react to various situations in our life. Situations that make us feel sad, severe grief, for example, if we lose a loved one, or sometimes if you win the lottery or you pass your exams or your family friend or something comes over, you know, there's that period of elatedness.
Yeah.
But when you mention pathological, you mean it is over and beyond that regular range in which our
That's right.
mood normally fluctuates.
That's right.
Severe depression being far beyond feeling just sad and for persistent periods of time, and elatedness far beyond just feeling extremely happy for significant periods of time, right?
Yes.
Okay.
Yes. Remember that at the moment we are using all these criteria,
Right.
and ICD-11, and before that ICD-10.
The international classification.
Yes, the
of
international
diseases,
classification of the World Health Organization,
Mm-hmm.
in a way followed the tremendous drive and the tremendous success of the American classification that is enshrined in the iterations of the DSM.
Right.
And the reason why I mention that is because, for example, when let me change subject. Do you know the guy who actually designed the car, the Mini? You know,
Okay.
the Mini, the famous Mini.
The scale.
Yes, was Sir Alex Isigornis
Right.
in the 1950s. That's a lie, in the 1960s.
Okay.
And he used to say that a camel is a horse that it is designed by a committee.
Right.
Yeah. So bring that to the way in which mania and melancholia and depression were then discussed and debated in the context of the committees of the DSM.
Right.
They used the famous box set method, a bunch of guys sitting around the table. So these are tremendous simplifications that we use to describe what's happening to our patients.
So what would be some of the key differences between, so for the person who's watching this podcast, and they may have a family member who've been told that they have bipolar disorder, or they hear the word bipolar disorder, what are the key differences between bipolar 1 and bipolar 2? And is there an important difference in terms of its distinction for diagnosis and treatment?
Yes, there are. And I guess that the main distinction would refer to the classical presentation. In a bipolar 1, for instance, a patient with mania, you will rapidly be aware that there's something fundamentally wrong happening to your loved one. You know, someone who is relatively shy and suddenly is going out, spending money, taking all sort of wrong decisions, etc. It will be a dramatic change. Likewise, with the depressive episode, it would be a person who is literally dejected, down in the dumps, who is not eating, who before was going out with you and has no social life whatsoever. And it would be fairly rapid. So that is what we call the classical phenotype. The bipolar 2 would be...
That would be bipolar 1.
That's a bipolar 1, yes. The bipolar 2 was recognized by the last psychiatrist who was able to have neurology and psychiatry in his head, who was a German psychiatrist in Berlin at the turn of the century. His name was Mendel, nothing to do with the other Mendel of genetics. And he would identify the notion of hypomania. So this would refer to someone or somebody who, in the case of the hypomanic symptoms, experiences a subtle change in his or her personality, becomes more talkative than usual, initiates a number of activities, but up to a certain point can be contained or is not so disturbing. And
they can usually get away with it.
Yes, they do. Right. They do until the evolution or the progression of the illness is such, and this is where the issue of the mixed symptoms comes about, because it's never pure hypomania.
Simply tell us, what does the mixed symptoms mean?
You know what? The best guy who described this was a guy called Weigand, who said we get and he was a disciple of Kraepelin. He would talk about the affects, the cognitions, and the motor function. And you get this grid: affect, cognition, motor function, affect, cognition, motor function. So you can have a depressed affect, a depressed mood, but then from the point of view of your motor functions, you can be restless, agitated, talkative. And that's the notion that you and I learned, because you come from where I come from, that you and I learned as agitated depression. That then shifts into, okay, this is then, if you get a depressed mood with psychomotor restlessness, that's agitated depression. But if you get like an elated mood with psychomotor restlessness, then you get typical mania. So if you do the different combinations, you could see them reflected. DSM-5 draws a little bit on that, because before, when we were talking about mixed, it was very difficult for the residents to reconcile. Oh, you have mania and you are depressed, and this is where then the classical term of it's
bipolarity,
gets
challenged.
Gets challenged. Exactly.
So why is bipolar disorder often misdiagnosed, especially as depression? I mean, what steps can clinicians do to help get an accurate diagnosis?
Because, as you know, the great longitudinal studies, they show that a significant proportion of patients with bipolar they experience one or two manic episodes. I'm referring to the classical phenotype, the bipolar one, but then the most frequent one is the depressive episode. So the polarity, it's towards depression. So imagine if the illness starts in that form, in the form of depression.
Right.
And you know that sooner or later, because there is probably a family diathesis, that you know that that patient could suffer from a manic episode later. I mean, until that manic episode takes place, there will be a group of psychiatrists who would be very resistant to actually make a diagnosis of bipolar disorder.
Right.
They would say, well, this appears as a depression. And then what you do is you go and you treat the depression.
If there's a strong family history, so you have family physicians, they will see somebody with depression. There's a strong family history of bipolar disorder.
Yes.
They're treating the patient for depression using a serotonin-specific reuptake inhibitor.
Yes.
Potentially going up to an SNRI.
Yes.
Serotonin norepinephrine reuptake inhibitor.
Yes.
Which may then potentially get them to, the patient may potentially switch to mania.
That's right.
How can that be prevented, or what kind of steps or cautions should family physicians or even psychiatrists in the community like myself should be wary of?
So you said it yourself, the moment that you know that there is a very strong history of bipolar disorder, then you have to tread with great caution. There is an American psychiatrist who I respect profoundly. You know him, Nasir Ghami. And Nasir Ghami would do everything in his hands not to use an antidepressant. If he sees this type of patient, he would go for a mood stabilizer.
Right.
And as you know, we now believe that the second and the third generation antipsychotics, that has completely different family of medications, some of them have a mood stabilizing effect.
So even for depression?
Even for depression. As you know, quetiapine is the one that in Canada is approved. In the form of monotherapy.
Correct.
For depression. So that would be a far more cautious, way to maneuver. But remember that a very good friend of ours, who is also who works at Kingston at the Department of Psychiatry, around the end of 2013, came up with some guidelines, and they published these guidelines in the American Journal of Psychiatry, which is kind of like a mainstream journal that we use. And what they say is, if you have to use an antidepressant, be very cautious. Try to use an SSRI. Do not use the norepinephrine and serotonin reuptake inhibitors, or use bupropion. But if you have to use the SSRIs, again, be cautious. Don't use the tricyclics.
No,
That's very good. And then came the bit about, and if you can protect them with a mood stabilizer, please do.
Fantastic. That's really useful. What do we currently understand about the causes of bipolar disorder? Genetics, brain chemistry, environmental factors?
When you talk about environmental factors, that propels me, I don't know, I have this flash, propels me to a very interesting study that I'm sure that you read because you get the British Journal like I do. This is a study that came around 2005. Do you remember that it was a study that was done in Japan? Depending on the prefectures, exactly, because there is no internal mobility. People stay put. And you know exactly that where people are taking the water from, where the drinking water, and you can actually measure the lithium levels in the drinking water. And if you compare different prefectures, there is a suicide index that you can measure for each prefecture. In those prefectures where the lithium in parts per million in the water is high, the suicide goes down. And then in those prefectures where it is the opposite, the lithium is low, the suicide index goes up. We don't know why, but we know that in bipolar patients, and this was studied by Baldessarini, who is a big guy, he shows that longitudinally, those patients who have been exposed to lithium with a classical phenotype, the number of suicide is lower than those who have not been treated with lithium in the long term.
Other causes of bipolar disorder, I mean, obviously we know that family history plays
That's
a
fundamental.
significant
Yes.
role, but a person could perhaps have be genetically inclined to develop bipolar disorder, but
Yes.
may never do. What are the kind of things that could potentially trigger them to develop?
Our main concern, and the one that we tend to see, is the use of substance, of illegal substances.
Right.
And in that sense, that's why we have to be very, very, very cautious there. And it is as if the substance, leaves the lead, and then you get up with,
Right.
it comes up in the form of a manic episode.
Right.
And this is why the Armenian guy called Akiskal, who you have memorized too, came up with the different disorders. He talks about the bipolar 1, bipolar 2, bipolar 3, 3.5, 4, depending on, for example, is there a consumption of substance that have precipitated this? What about antidepressants? That antidepressants in a patient who has that predisposition, the risk of
would those different precipitators lead to a different prognosis?
Yes, they can.
Potentially.
Yes, they can. We thought that the bipolar 2 said, well, this is a mild periods of mania or hypomania followed by severe episodes of depression. And we always thought, well, this is a kind of like a soft variety. But the emerging picture was that the suicides happened in the bipolar 2. So that's why it became a frightening condition, and that's why we have to be, the prognosis, changes, and why we have to be more aggressive here or there, depending on the pharmacology.
Right. So can people with bipolar disorder lead stable, productive lives?
Yes, they can.
And what kind of lifestyle habits or routines make the biggest difference in their long term?
Of course they can. We have some excellent treatments for this. You have heard me talking about lithium already, which is still the gold standard, or it is regarded as the gold standard. And certainly, and you have to allow me to give the historical note. Bipolar disorder or manic depressive illness, they're not exactly the same, but these episodes of mania or these episodes of agitation followed by severe depression is something that we have identified in a very consistent way for more than 2,000 years. So the Greek authors knew, and they knew from the, like that, I'm talking about Hippocrates, etc., that lifestyle decisions, routines, sleeping hours, exposing yourself to stressors were all potentially dangerous. And that's why you have to have fundamental lifestyle. You have to take fundamental lifestyle decisions in this sense, having your routines, avoiding excesses, etc.
So what advice would you give families or partners supporting somebody with bipolar disorder, especially during the early signs of a relapse?
One of the first advices that I give them when I bring them, and I try to bring them into the office, both of them, a couple, partners, would be always to be frank and to allow for the person who suffers the disorder, because sometimes your insight goes through the window, is to allow the partner to contact their family physician or their psychiatrist if necessary, and to have that kind of trust in your partner. Certainly, that's one of those. And I dedicate a significant amount of time to look into issues of adherence to the treatments, and in particular to the medication.
It's interesting you say that, because I had a patient who had told me that obviously during the early signs of a relapse, they would not know that they are going into a relapse. And it was usually their family members or friends who would notice that.
Yes, they would.
And that they developed almost like contract with their friends and family when they were well, to say, look, if you notice that things are going, not in the right direction, if you feel that I might be heading towards a manic episode, I want you to just, they had some kind of a mechanism to say, look, you need help right now. And then to show that contract to them, just so that they had an erase.
Exactly.
So that prior to a time where they lose insight into what they're going through, they have somebody who they trust, one or two key people who they trust, who would not just suddenly say this out of just willy-nilly.
Exactly. So, in that sense, what comes to my mind is This is one of the most elegant papers I've ever read. It's a 1994 paper, and it is very elegant, and it rings true because it's what you see when you see patients. And what they did is they started checking precisely this: what is the first? What happens? What are the prodromes, the initial phases that would lead to this? And one of the things that we see is that the relatives notices that the patients, the number of hours that they sleep starts reducing.
And let me jump in with that. So patients, they are on mood stabilizers, people who have an established diagnosis of bipolar disorder.
Yes.
They have been on a mood stabilizer for years, and they've done really well on the relevant mood stabilizer, whether it was lithium, sodium valproate, or lamotrigine, for example.
Right.
However, due to various stressors, they feel a relapse occurring,
Yes.
and their sleep starts to get affected.
Oh, terrible.
Now, the question is obviously, the reduction in sleep is a manifestation of the bipolar disorder coming back, or I should say, the mania reemerging. So, treating the mania helps with the sleep. The idea is not to sedate the person with zopiclone or other sedatives per se, correct?
Yes.
So the idea would be to more aggressive support of the existing treatment, whether it be with an antipsychotic, for example, in the evening, which supports the existing treatment of the bipolar disorder, which would help with the sleep as well. Am I correct in?
Yes, you are. Basically what you are describing is what Nasir Ghaemi calls the etiological treatment versus the symptomatic one. Right. Of course, you can sedate the patient if you want, but, whereas by increasing the lithium, that sometimes you can, but sometimes you can't, by, adding on, in this particular case, some of the new third generation antipsychotics, that would be a far more efficacious and clinically sound way than just, adding on, as you said, zopiclone. I mean, you can do that if you want, but my educated guess is that sooner or later you will have to go be more aggressive.
Yeah.
Yes.
So lastly, and we're hugely thankful for your time. So lastly, what are some of the promising research going on with bipolar disorder and in bipolar research? Medications, neurostimulation, other interventions?
We should not neglect the psychoeducation, because the psychoeducation is fundamental, at the time of, as you said, showing the patient what would be the early indicators of the illness. And we tend to minimize that because we know that we have very efficacious medications, and we tend to focus that. But it is true that the medications, we are getting better and better medications all the time, with not so many side effects, that try to treat the target of, that they target the what's fundamentally wrong in the illness. And, we have some new attractive, with the second generations and the third generations antipsychotic, we have new options and a new variety.
Is transcranial magnetic stimulation
for depression
depression
is fantastic.
Right.
And as you know, because we have talked about this before, that is the pretty phase of neurostimulation.
And actually, when I read the guidelines, that should be addressed first.
Yes.
Right.
Yes,
right.
The problem that we have in Ontario is that the moment that that's going to be costly, and OHIP doesn't
cover TMS at the
exactly.
moment.
But it is incredibly well tolerated.
Absolutely.
You don't need to anesthetize the patient.
They can walk in, walk out the same day. Yeah.
Yes, and we are now using the theta burst stimulation.
Exactly.
That it is a particular type of paradigm that in 10 minutes. You get the patient out of the office.
Any last words for the listeners in terms of bipolar disorder? Any kind of advice?
This is going to sound like very lame, but follow what your doctor tells you. And that's one of the problems that we have. Yes, that would be my main
I really appreciate
advice.
it. Thank you so much for your time, Dr. Cabrera. It's been an absolute pleasure.
And thank you very much for asking me to be here. Thank you.
Thank you.